All right, so the next lecture is on pneumothorax. We're going to talk about what critically ill patient scenarios you may be using to evaluate for a pneumothorax using lung ultrasound. So again, remember there are a lot of signs. Now we've gone through A lines and B lines, lung sliding. We're going to go through a few more in this lecture, specifically lung point, stratosphere sign, barcode sign. So remember, we can find a lot of these things. We can find pneumothoraces, hemothoraces. This particular one, again, we're going to focus on pneumothorax. What are the questions? Most of the questions for pneumothorax are related to whether the patient needs an acute chest tube or not. In the critical care, mostly it's related to an acute trauma situation. I've not used it in other situations, primarily because most of the signs found in pneumothorax are found in a lot of other disease processes that more commonly affect ICU patients. So our focus questions on pneumothorax is lung sliding present? And how far lateral is the lung sliding absent? And I'll discuss a little bit more about that, about what I mean by that. You can use a few different type of probes. You can use the cardiac probe, the abdomen probe, or even the vascular probe, because the vascular probe actually does zoom in the pleura the best. One other thing I recommend is now with the newer machines, they do have lung presets. This was not available until about a year or two ago. Most of the machines did not have lung presets. Remember, lung presets essentially keep artifacts in, and that kind of helps us out to be able to find lung sliding. So ultrasound was first used for pneumothorax in 1986, first described in animals. In a normal lung, the visceral and parietal pleura are closely associated, and ultrasound normally shows a shimmering or sliding at the pleural interface. Remember, I said sliding is the word that we're actually using, but sometimes you do see these different things in literature. Absence of this indicates a pneumothorax. Remember, absence of this can also be in other disease processes, such as patient is not breathing, main stem intubation, pneumonias, aspiration pneumonias. So don't be tricked by thinking that just because there is no lung sliding that the patient has a pneumothorax. In trauma patients, ultrasound was shown to be more than twice as sensitive for detecting occult pneumothoraces with a similarly high specificity. I mentioned here comet tails, even though we don't see it in literature as much. They are ultrasound artifacts that arise when ultrasound encounters small air fluid interfaces. You'll hear a little bit more about this in the pulmonary edema lecture, but essentially comet tails, the word is getting less and less in literature, but I still put it here because sometimes people see it. If you do see comet tails, that sometimes makes it easier for you to see lung sliding when the comet tails are moving to and fro. Just a few introduction points about pneumothorax. Remember, we normally had used chest radiography in the past. Ultrasound relies on the fact that free air is lighter than normal aerated lung tissue and accumulates in non-dependent areas of the thoracic cavity. Multiple studies show that ultrasound is more sensitive than supine chest radiography, and you can see these are just a few. This is from 2006, but there's tons of articles that talk about this. So how do we evaluate for pneumothorax using ultrasound? Well, the patients usually should be laying supine. If you're looking for small apical pneumothoraces and the patient can tolerate it, you can have them sit up. For the best view of the pleura, the high-frequency linear array probe or vascular probe is the best. You can start at the mid-clavicular line at the 3rd through 5th intercostal space and kind of fan all the way out to the mid-axillary line, but you should definitely look at several intercostal spaces. The lung point is actually not a sign, but it is a terminology you see. It's an area where the pneumothorax interfaces with the chest wall. So lung sliding, remember I talked about how important it is? I'm going to show you a few slides again of lung sliding because it is so important. But the parietal and visceral pleura can be seen sliding to each other. You can actually see this graphically depicted using the M mode. Before we were able to save a lot of clips, people used M mode a lot, and that's why you do see in literature still people talking about seashore sign and stratosphere sign, or a beach sign and a barcode sign. So essentially what I want to talk to you about is, as the patient is graphically, so in the past when they did not have video clips, you can actually put an M mode going through the pleura, and you can see if the patient had lung sliding, it would show up similar to this over here, where you see no motion, which is the chest wall, and then when you started seeing motion, it would have a configuration like this. So if you look at it, it kind of looks like you're on a beach with the ocean, or a seashore sign. If you had a pneumothorax, you would go straight through, and essentially it would look the same the whole time. And that indicates kind of like it looks like an old barcode or stratosphere sign. So here is similar when I had the lecture on basic lung ultrasound. Essentially this shows lung sliding. This is very important for you to be able to acknowledge that you can see the lung sliding here. You can kind of compare it to even up here, where if you look at this hyperechoic line up here, you don't see any sliding at all. So if you can tell that, that's very important, because with a pneumothorax, this line right here would look just like this one. Now remember, you can barely see the rib shadow right here, and the lung pleura is always 0.5 to 1 centimeter right below the rib shadow. So here's a rib, and you can see the lung pleura. Here's a pneumothorax with a, they call it lead point on this, but it's also called a lung point. So essentially you can see absence of lung sliding on this side, and you can see lung sliding present on this side. So you can see as the patient takes a deep breath, you see sliding over here and no sliding over here. Don't worry if you don't see it exactly. I have a few more slides on this. So let's go back and just show you a patient with no lung sliding. So this is a better picture. This is a vascular probe that they're using. You see soft tissue. You see a rib with a rib shadow. Rib with a rib shadow. This is the pleura. And you see as the patient takes a deep breath, you can see the chest wall moving. The ribs are moving, but this lung is not sliding. When you compare it to the previous one, you can see no lung sliding. And again, I'm going to show you another image with lung sliding, and that might make it easier for you to see. So this is a barcode sign. This is the similar patient with an M mode placed right here. And you can see that it looks kind of like similar the whole way. It's not as clear as the pictures you see, but you can definitely see that there's no lung sliding. So here's another image from one of our ICU patients where you essentially see no sliding on the right side of the screen, and you see sliding on the left side of the screen. This is soft tissue up here. This is a rib with a rib head. Rib, rib shadow, rib shadow. So you know that this is the pleura. And then you look, this has sliding, and this has no sliding. Again, remember, the whole point of me showing you this is so that you don't get confused with hyperechoic structures in the soft tissue. So you always look for the rib head first, and then look a half centimeter below. All right, so this image here shows really good lung sliding. So you see a rib with a rib shadow. These are actually B lines. If I increase the depth, you would actually see these lines shoot all the way down to the bottom. But I wanted to again show you what sliding looks like. So I show some no sliding and some sliding just so you get a sense of what no sliding looks like. Another thing I would like to talk about is a thing called a lung pulse. So we see this frequently, and sometimes I don't think most of the time people even realize what they're looking at, but essentially here's a rib with a rib shadow, rib with a rib shadow. You see the lung pleura. You see an A line, which is a horizontal line. It's actually equidistant from the chest wall to the pleura. And as the heart is beating, you kind of see it pulsing. This doesn't look like regular sliding. If the patient was breathing 80, 90 times a minute, you might see something similar to this, but probably this is more on the left side of the chest. With the heart beating, you can see this pulse. When you see a lung pulse, that actually indicates that there is no pneumothorax. If you had a pneumothorax, just because you don't have a lung pulse does not mean you have a pneumothorax. But when you have the presence of a lung pulse, it reliably rules out a pneumothorax on that side. Now again, just to put it all together, remember what I showed you. You can actually take an image here. You can take an image here. You can take an image here. You can take an image. You can take an image as many places as you want. But what I recommend is in trauma patients, you start at the apex. If you see lung sliding, it's very less likely that you have a pneumothorax that starts in the posterior region, although it could because you can have rib fractures anywhere. But most of the time, what you want to do is start at the apex, and then you can do a couple of points, but if you see no lung sliding, you should actually go here, you should go here, you should go here, and you should go all the way down to the axilla until you actually see lung sliding. So some of the literature shows that if you actually go past the mid-clavicular line or the nipple line, that 90% of those patients ended up getting chest tubes. So how can you use evaluation of pneumothorax in the trauma setting? You can actually use it by kind of saying that if it goes past the mid-clavicular or nipple line, that patient may need a chest tube sooner than later. Obviously, if you see no lung sliding all the way down to the mid-axillary line, it's probably a large pneumothorax on the side, and you may actually be able to pick that up without lung ultrasound by just looking at the chest wall movement. So remember, when you're looking for pneumothorax, we have a couple of questions. Is the lung sliding present? And how far lateral is the lung sliding absent? Again, remember, lung sliding being absent does not mean pneumothorax. You can have other conditions such as pneumonia, main stem intubation, patient apnea, and a whole host of other reasons why the patient may have absence of lung sliding. But in the appropriate situation, primarily for me, mostly in the acute trauma patient, a pneumothorax eval could help you out determining whether you need a chest tube or not.